Pretend your esophagus is like that little chamber in a carpenter's level. And if you just offset that level a little bit, that fluid's going to go down and that bubble's going to go up the other direction. If that's your esophagus, you're helping the clearance mechanism by elevating the head of your bed. Very important. You don't have to do very much of it. I mean, I tell people to put blocks under the head post of the bed, and just a little elevation, a couple inches, can be very effective. We tell our patients also to avoid recumbency, avoid lying down within 2.5 to 3 hours after eating. That's the time. That's the time when this happens predominantly. Now, there's a lot of medications that play a role. There's a very good article in one of our journals in August that goes over why is the incidence of this all going up in this country? Why is there such a dramatic increase in reflux, in Barrett's, in esophageal adenocarcinoma or cancer? Why did this all happen since 1970? Well, this article made a strong point for saying that we're using a lot of medications now that have effects that can cause reflux, and they're important medications for their problems, for hypertension, for heart disease. But they do have effects on the sphincter muscle. They do have effects on the ability of the stomach to empty, on the clearance mechanism of the esophagus. Presents a difficult problem. I can't take patients and tell them, come off these medications. These are important medicines. We work around them. But medicines like calcium channel blockers, medicines like nitrates, beta blockers, aminophylline, theophylline derivatives, anticholinergics, all have effects on the sphincter and the motility or the muscle activity that promote reflux. Treatment strategy, let's go into medications, over-the-counter medications. Antacids, time-honored. These things work. They neutralize acid. They work quickly. They don't work very long. If someone has reflux 24 hours a day, they're going to have to take antacids every hour or 2 hours and probably develop a lot of diarrhea from that. So they are very effective in the short run. They're very effective if you're out there and you feel miserable to take an antacid, you'll get relief. But they're going to last minutes. Over-the-counter H2 blocker medication. H2 blockers are Tagamet, Zantac, Pepcid, Axid. They're sold at lower doses over the counter. These are good medications for patients who have predictable mild reflux disease. If you know you're going out on a Friday evening and you're going to eat a little late and overeat and have that cocktail and do something that doesn't necessarily going to help your reflux, you can pre-medicate. And these work. They work for patients with mild reflux when it's predictable like that and when you can take them as needed. There are, and I don't encourage these in everybody, but salivary stimulating agents, sucking candies, chewing gum. If you don't have gas bloat type symptoms, they do increase the amount of saliva you produce. Saliva is a good thing for reflux. It washes down the acid. Saliva has bicarbonate. It neutralizes acid. And saliva has mucus, which coats the esophageal lining and can afford it some protection. That's why hypersalivation or water breath is the body's defense mechanism. You can increase saliva by using hard sucking candies or things like that. These are all things you can do. You don't need to see a physician for them. Let's go to phase 2A of the step-up approach, which is using prescription dose H2 blockers. This is the Tagamets, the Zantac, the Axid, the Pepcids. These are at higher doses. You can get relief in a significant number of patients with these. You can get relief with a dose of these medications for maybe up to 10 or 12 hours. They are very effective. I don't see a lot of patients on these medications that are doing well. The patients I generally see are the patients not doing well on these medications. When we get beyond that point, we get to phase 2B of our step-up approach, which is medications that are gaining increasing popularity. Big market players, the proton pump inhibitor medications, Prilosec, Prevacid, Acifex, and now Protonix. There's 4 medications in that list available now. These are great drugs. They paralyze the acid pump. They turn it off. They work on that final common pathway in the stomach that makes acid, and they shut it down. They're very effective. They're once-a-day medications. Compliance is fantastic. They're very expensive, and that's an issue. They're a lot of money. And if you commit a patient to long-term use with the proton pump inhibitors, cost it can be a very big issue, especially if patients are on numerous other medications that cost a lot of money. There was a lot of concern about these medications when they first came out, about potential long-term effects, adverse reactions, etc. How long can you use these before you have to stop them? Those concerns, those fears have been allayed by just practice and usage. These drugs were available in Europe way before they were available here, and time has tested them, and time has been in our favor that they're very safe. This is a slide I have about long-term safety issues, and you can see it doesn't do very much. It doesn't really impair digestion. You don't have to worry too much about a slight reduction in cobalamin levels. There's a hormone called gastrin that used to be a concern. That was the original fear, that if the gastrin hormone goes up in response to these medications, which can happen, that maybe that's going to cause some problems like cell turnover, increase your cancer risk. We see this gastrin level go up. It doesn't cause anything. We found it really doesn't do much. And that's been our experience with it. I follow it periodically in some patients. I've had patients that develop very high gastrin levels. I've never had a patient develop any other problem from long-term use of these medications.